Hi, everyone. We'll just give a few moments to let everybody trickle in. Thank you, everyone, for joining us. We're just giving a couple minutes to let everybody come in and settle down. Okay, we'll get going. Hi, my name is Danielle Pace. I am the Chief Pharmacist Officer at CPHA. Thank you, everyone, for joining us today. Before we begin, I'd like to acknowledge that we are meeting today virtually from coast to coast on ancestral and unceded territory of all the Inuit, Métis, and First Nations people who have been stewards of this land for generations. We honor and acknowledge them. To get us started, I'll run through a few housekeeping notes. Today's session will begin with some opening remarks and a conversation with our very special guest, the Honorable Carolyn Bennett. The minister's remarks will be followed by a brief presentation and panel discussion and Q&A with our three expert panelists that we are very thrilled to have with us today. Please use the Q&A box to submit any questions for technical support and for our speaker, and we'll get to as many as we can. This session is not accredited. However, you will receive a follow-up email confirming attendance if you need it for your own learning records. This session will be recorded and a video will be made available in the next week or so at pharmacist.ca/webinar. And that'll include any other session resources we provide. And then finally, when the webinar is over, please do not close your window right away. An evaluation survey will pop up on your screen. And we'd love to hear your feedback so that we can continue to bring you current and relevant content. So with that, I'll invite Minister to turn on her camera. It is my pleasure to introduce you to the Honorable Carolyn Bennett, Minister of Mental Health and Addictions and Associate Minister of Health. Minister Bennett was a family physician prior to entering the world of politics in 1997. In her current role in Parliament, she works with the Minister of Health to build a healthier future with a particular focus on the health inequities of Indigenous peoples, Black Canadians, and vulnerable Canadians. She is also dedicated to ensuring that mental health care is treated as a full and equal part of our universal healthcare system. She works with provinces and territories to lead a whole of society approach to address problematic substance use in Canada. Minister Bennett, thank you so much for joining us today. I know the issue of safe supply is one that you are particularly passionate about and that the federal government has championed. Last fall, we surveyed pharmacists about safe supply, and you'll be pleased to know that 76% said that they believed they had a role to play in providing safe supply. Minister, perhaps I can turn it over to you now to provide your thoughts on why this is such an important harm reduction strategy and how pharmacists can play a core part of addressing opioid use disorder.
Well, thank you, Danielle, and it is a total honor for me to come and be part of this truly important conversation. Before I begin, I want to thank you for the land acknowledgement that you began with, but also to acknowledge that I'm speaking to you from the traditional unceded territory of the Algonquin and Anishinaabe people. And aujourd'hui, nous nous rencontrons pour parler l'approvisionnement en drogues toxiques et ce que nous pouvons faire pour offrir un approvisionnement sûr et réduire les risques. Though I first want to recognize the critical role that pharmacists play in patient care and acknowledge that really impressive survey, but providing clinical care and education for patients and caregivers in supporting their goals of their therapy. And so from my time practicing in rural Canada to my experience that I told some of the executive yesterday about on the Ontario government panel decades ago on expanding the role of pharmacists. I want you all to know that you are such an essential part of our healthcare workforce. I think too often underutilized for your expertise, your accessibility, but also the trusting relationships that you build with your clients. And so while vital to public health long before the pandemic, we know that COVID-19 has pushed pharmacists to the front row to take on an even greater role in patient care, and all the while maintaining those important face-to-face relationships with their patients. So we saw the extraordinary role that you played in the vaccine rollout, and aujourd'hui, j'aimerais exprimer ma sincère gratitude pour tout ce que vous faites et souligner le mois d'appréciation des pharmaciens. La crise des surdoses a un effet significatif sur la santé psychologique et physique des Canadiens et des peuples autochtones. I don't know if any of you were able to see the Take Note debate in the House of Commons last month, led by Dr. Hanley, the MP for the Yukon, but it was heartbreaking, just documenting so many truly personal stories of MPs, families, and friends. So as I think we're moving in terms of the moving beyond the stereotypic view of people using drugs and moving on as the Canada's first federal minister of mental health and addiction, how important it is that I hear directly from you, from experts like yourselves, obviously with those with lived and living experience as well, but we want to hear from you how you see that we can reduce the harms and the numbers of lives lost. So since I think you all know these numbers, since March 2020, many provinces and territories have reported the historic levels of opioid-related deaths and harms. And in fact, over 25,000 lives have been lost since January 2016. These deaths are deeply saddening and tragic, but I think as we walked the downtown east side, these aren't just numbers. These are people's family members and friends, and they have names. And groups like Moms Stop the Harm, I think, have put a very, very important face on each of these losses, and really the responsibility for all of us to do better. And it is why I think we all see that the deaths underscore the importance and urgency of the conversation that we're going to have today, and that I think there's nobody in this group that thinks the status quo is okay. The task force that Minister Haiju struck last spring really told us that we had to take bold action, and it had to be significant change. So I think Canadians are starting to understand what I guess a lot of us have known for a long time as you do your work, that, you know, how 1958, the first Director General of the World Health Organization, who was a Canadian veteran, Brock Chisholm, who started the the understanding that there can be no health without mental health. And I think that throughout COVID, we've also come to learn that we can be apart without being alone. And so some of the new virtual ways of giving care and listening to one another, like today, means that we can continue to make progress. So, nous reconnaissons le besoin de travailler collaborativement entre les ordres de gouvernement et avec les parties prenantes pour remplir les besoins en santé mentale et en consommation des substances des Canadiens dans les années à venir. So this is what we have done and what we will continue to do. But we want to be removing and are, as some of you know, removing the federal barriers to medication for people with substance use disorders and issuing that class exemption for pharmacists to make it easier for people to access much needed services and medications during the pandemic. So, but it's really been since 2016 that our government's approach to the overdose crisis, it was guided by the Canadian Drugs and Substances Strategy, which includes all 4 pillars of prevention, treatment, and enforcement, but of course, harm reduction. And so, for instance, since 2015, the number of federally approved supervised consumption sites has grown from 1 to 38 and have reversed 27,000 overdoses without a single death. So, however, we also know that we need to explore additional approaches to save lives now. L'approvisionnement sûr sera essentiel et je suis encouragée de voir les pharmaciens s'engager si activement dans la discussion. As you may know, we are currently funding a number of safer supply pilot projects across the country, as well as a national safer supply community of practice. So that, as I think most of you noticed, that includes recently authorizing diacetylmorphine hydrochloride as a supervised injectable opioid agonist treatment for adult patients with severe opioid use disorder. Bien que je sache que le but de la discussion aujourd'hui est de parler de l'approvisionnement plus sûr d'opioïdes, je suis également ouverte à entendre votre opinion sur d'autres substances. It is critical that we address substance use as a health issue and continue to look at ways to divert people who use drugs from the criminal justice system and towards the healthcare system by providing social supports, including effective drug treatment services. And I think, as you all know, that sometimes that first relationship with a trusted provider can be the way forward for so many people. So it's never been more important for all of us, all levels of government, communities, partners, and stakeholders to work together to turn the tide of this crisis and deal with the stigma of people using drugs. And as we grapple with this devastating crisis, it's evident that all orders of government must continue working together with our partners to advance innovative solutions to help people affected by opioid use and save lives. So, il y a encore beaucoup de travail à faire, mais j'ai hâte de travailler avec vous et de vous entendre. With that, I turn it back to you, Danielle. Thank you. Merci, Miigwech.
Thank you so much. That what you've shared just highlights how important it is for us to come together and what we can do when the impact we can have when we approach this crisis with an open mind and a willingness to be solution focused. Do we have time for a question, Minister? Awesome. So, during the pandemic, the federal government enabled some really important exemptions under CDSA, giving additional authorities to pharmacists so they can maintain continuity of care. And I understand the government has extended these to 2026 and maybe looking at making them permanent. How do you see the role of pharmacists in this area of opioid care?
Well, I just have to say that this is an essential member of the team. I think that when people talk about their molecules, you know those better than anybody, and what might work for patients in terms of safer supply, a safer option for that. This is going to be hand in glove with pharmacists to really be able to help people stay safe and again meet their goals. So I think that we are seeing coast to coast to coast that people want the true pharma care, the care that you give as pharmacists is going to be important in not only primary care, but in crisis intervention and in really providing an end to this crisis.
That's great. The last thing I'll ask is, these new legislative changes suggest that Health Canada is thinking very progressively about its approach when it comes to addressing the opioid crisis. And do you anticipate that we'll start to see a shift towards a more inclusive system that centers around the personalization of care and meeting Canadians where they're at?
Absolutely, and I think it really is about us creating the evidence and the research to show what works and what doesn't work, and for us to then continue funding what works and to stop funding what doesn't work or what's stuck in some sort of ideology. That this is about a health issue, and that we have an obligation as health professionals to keep people alive and not send them to the street where they are dying. So absolutely, we want to with your help to be able to explore these innovative and creative approaches and then create that evidence to keep going.
Absolutely. Well, thank you so much once again for being here today, Minister, and for all the work that you are doing to support Canadians. We look forward to working with you, and we know that pharmacists and pharmacy can support you in achieving many of our shared priorities. So with that, I will say adieu, and we will invite our panelists to join us. Thank you so much. Okay, wonderful. So I will now introduce our panel. So I'll have them introduce themselves. We'll begin with Craig Plain.
Hi, thanks for joining everybody. I'm really happy to be here, and I'm happy that a lot of people are interested in this topic. It's something very, very close to me. I've spent a lot of years in the downtown east side of Vancouver, coming up with some very innovative practices, designing our own sort of injectable opioid agonist treatment program that we ran successfully for 2 years, getting take-home naloxone kits into community pharmacies in BC. So we've done a lot of work down there, and I'm happy to be a part of this. I've recently moved to Kelowna and hoping to kind of start a pharmacy with some similar outreach and innovative pharmacy progressions that I can bring here and help a new community.
Thank you so much, Craig. We're excited to learn more about your work and look forward to your presentation. Next on our panel, we have Dr. Maria Zhang.
Thanks, Danielle. Hi, everyone. My name is Maria Zhang. I am a clinician educator jointly between the Centre for Addiction and Mental Health, where I currently am in downtown Toronto, Ontario, and also with the Leslie Dan Faculty of Pharmacy at the University of Toronto, where the focus of my teaching and research is substance use. And I've also had the privilege to participate in the creation of provincial and national guidance documents as it relates to opioid agonist treatment, and super appreciative of the opportunity and looking forward to learning from and with you all.
Thank you, Maria. And rounding off, we have Dr. Mike Beasley.
Thanks, Danielle. Yes, my name is Mike Baisley. I'm a professor at the School of Pharmacy at the University of Waterloo. So I'm coming from downtown Kitchener today. It was great to hear Minister Bennett's words, and I'm really looking forward to listening to Craig's talk and to have him share his experiences with everyone and to participate in the panel. So thank you for attending, and I look forward to engaging with you.
Oh. Well, welcome to all three of you. Thank you again for being here. We're going to start today's session, as alluded to, with Craig doing a presentation for us, and then move into some discussion and questions for our participants. As Craig is getting ready with his presentation, we wanted to get a sense of who is in the audience today. So Chrisanne, if you could put up a polling question. We just want you to tell us a little bit about your experience with this area. And, you know, as I read this questions about sort of getting a sense of who is dispensing what, I suspect that there are some discrepancies. You know, dispensing opioids for pain is common, but I don't know if that's necessarily the case for the other modalities that are showcased here. I don't know if our panelists have any thoughts on that. One of the things that struck me when I was thinking about this particular topic was how there's also a little bit of stigma around the safe supply, opioid use disorder, and is there something that we can do to help address that as a profession, as a community? I see parallels to mental health. You know, we're starting to get more comfortable talking about mental health as a condition. I mean, the pandemic has made that, has highlighted the need for that. But I wonder if there's some similarities in terms of moving to a space where it's not as taboo. So these are the results. Do our panelists have any thoughts on where we're at? It looks like there's quite a range.
I think it's really encouraging to see that there is alignment with respect to the pharmacists who are dispensing opioids for pain, but also some of the evidence-based treatment approaches for opioid use disorder and harm reduction by way of take-home naloxone kits. I was telling Danielle and the other panelists that this is a question I frequently include in our third year pharmacy class, because it is interesting to kind of see the shifts over time where frequently, individuals who say they've worked in a pharmacy that dispenses opioids, you see their hands drop immediately, once we start talking about opioid agonist treatment. Take-home naloxone kits, I think, pharmacists have been absolutely instrumental in making available to Canadians. So it is great that there is kind of more commonality here, but as Danielle mentioned, even here, we can see that there's discrepancies. And I'm assuming the 256 attendees today, perhaps there's an element of us preaching to the choir as well. So it'd be interesting to see what the national kind of data would look like.
Okay, with that, I will turn it over to Craig.
Hello. So thank you very much. We have a lot to talk about in a very short amount of time, so I will apologize in advance if I speak a little on the fast side or go through some of the slides a bit quickly, but we have a lot to talk about. So if we can get going on the first slide here. So we could spend a lot of time looking at this and going over the data and really talking about it for an hour if we wanted to. But really what I really wanted to point out is this gives a bit of a snapshot between 2016 and 2021. But it's important to remember that between 2000 and 2017, there was actually a 600% increase in opioid overdoses in Canada. It's a bit shocking that either that stat was known and there wasn't enough done about it, or we sort of turned a blind eye to it. I don't know the answer to it, but knowing that, if we look at 2016, 2017, and 2018 on the purple bar graph on the right there, we can see that the numbers of deaths were increasing year after year after year, and it was a crisis. The good thing is that there was a lot of information on the media. The news was reporting all of this, And then in 2019, fortunately, we actually saw a decrease. Many provinces saw a decrease in the number of deaths. Some plateaued. So it was great news, right? Like, all these interventions we're doing, they're working. We're finally in a good place. Now let's try and get these numbers down. And then unfortunately, you see the last two bars, 2020, 2021, where the numbers went to levels that we just never thought we would see. We've got to try and figure out, well, what happened between 2019 and 2020. So if we go to the next slide, I think we know the answer. It's being rammed into our faces every day. COVID-19 happened. So, you know, again, this itself could be a 1-hour talk on how COVID-19 has affected the opioid overdose pandemic in Canada here. But quickly going through some different things that happened, I think we all know that there was a very different response from public health to these two pandemics. Looking at that graph in the previous page, I mean, the data goes up to June 2021. I mean, we have real-time data on how many people are in hospitals with COVID-19. So there was a lot of money and a lot of programs that were brought in very quickly when COVID-19 was declared a pandemic. And it was great. I mean, we saved thousands of lives, I'm sure. I just wish something similar could have been done with the opioid epidemic at a much earlier time. I don't think we'd be in the same position now that we're in had more been done sooner. Keep in mind that with a vulnerable population, a lot of people who use drugs, they do have underlying complicated medical conditions. So you take a vulnerable population, add COVID-19, and you're adding overdose risk altogether. That also increased the number of people that died, and which is why we saw that big spike in 2020. Access to health services changed with COVID-19 as well. And we saw a lot of people had harder times getting in to see their physicians. So restarting on, say, like a methadone prescription, whereas a client could maybe have the prescription canceled and within a day or two get a new prescription and get it, you know, reinitiated at the pharmacy. Sometimes it was taking a week or 2 weeks for people to arrange phone calls and phone appointments. Other health services like safe consumption sites, some closed down the early stages of COVID-19 and some had restricted hours. So obviously these things led to a higher number of deaths. This is just a very brief overview. There's so much more we could talk about as to what happened. But the poison or toxic illicit supply, to me, it really is one of the main things that it changed things profoundly, I think. So we've got to remember, drug poisoning affects people who use opioids. It affects people who use stimulants, people who use regularly, and people who use occasionally. So this illicit drug supply, it changed after the COVID-19 pandemic. The change in the composition and the manufacturing probably had the largest and longest lasting effects on the death rates across Canada. So there was a report that looked at a number of converging issues that made the illegal drug supply so unstable. So included things from disruption of precursor supply chains, shutdown of overseas synthesis facilities, and a disruption of drug shipping routes, to remember all the border closures that happened. So the whole illicit drug trade was just turned upside down, and there was a bit of a scramble. I mean, for the first time in the many years I'd worked in the downtown east side, there was a bit of an uncomfortable vibe. The newspapers were reporting and clients were reporting that there was only about a 7-day supply of illicit drugs left in the downtown east side, and there wasn't new stuff coming in per se. So we were being warned by some of our clients, like, you better make sure you have security. Like, this is, if we don't get something done quick in the next week or two, like it's going to be dangerous down here. And so this is where the last point comes up, the safer supply. Fortunately, it came in at just the right time. So go to the next slide. Let's just quickly go over what is safer supply. So the Canadian Association of People Who Use Drugs defines safe supply as a legal and regulated supply of drugs with mind or body altering properties that traditionally have been accessible only through the illicit drug market. Okay, so let's remember that. And the second bulletin, safer supply is not the same as opioid agonist treatment. Okay, so there's a difference there. We are really trying with the safer supply is to reduce the harms associated with the illicit drug supply. It's a very important difference. We are absolutely meeting people where they're at right now. It is nearly impossible to take somebody who's been using heroin or fentanyl on the street for years and convince them to come and take 30 milligrams of methadone once a day for a week, and then hopefully they can go up to 40 milligram the next week. It's not going to happen. You can't compete. We have to meet people where they're at now. And a reminder too, so the opioid agonist treatments, I mean, let's quickly go over it. So longer acting medications like your methadone, buprenorphine, slow release morphine. The idea is to have sort of a minimal euphoric effect, decreases cravings, decreases withdrawal, with this eventual goal with patients' goals in mind of lowering doses and potentially eliminating at some point. Whereas the safe supply includes drugs with mind and body altering effects, reduces barriers to access, and allows people who use drugs to self-regulate and to be taken unsupervised, at least unsupervised from us healthcare professionals. Hopefully, these are still potent drugs, and hopefully they're still in a situation where they're being supervised. We know with supervised consumption sites, there's been no deaths. So supervision is still key. So we'll just quickly go on to the next slide here for time. Now, who is eligible for safer supply? It's complicated. It's never easy. It depends on where the service is being provided. So the province you're in, the community you're in, and even just the prescribers in your community are kind of making a lot of these decisions on who's eligible for it. So in British Columbia, this came out right around the time that the illicit drug supply was disappearing in the downtown east side of Vancouver. So it came out just good time. People at risk of COVID-19 or suspected of being infected, great. Maybe a temporary eligibility thing if COVID-19 never goes away. But the other point is that people with a history of ongoing active substance use, or people at high risk of withdrawal, overdose, craving. So basically, if you are a person who uses drugs and you need this in BC anyways, you are eligible to get it, and you should be eligible to get it even after COVID-19 is if we're ever kind of through it. So if we go to the next slide. And then where can you access it in Canada? Well, there have been federal support, guidelines, and many potential models of safe supply. Despite that, uptake has been limited across Canada. So there's some pilot projects in BC, Ontario, New Brunswick. I feel like in BC, most of the safe supply medications, they are on our provincial formulary. So if doctors are willing to prescribe it, pharmacies can fill it, and there aren't a lot of barriers for us. Political will and funding have been large barriers to it. Certain provinces are still kind of on the model of taking a hard approach to working with people with opioid use disorder. Public drug plans in provinces don't always cover everything that maybe should be on the safer supply. So diacetylmorphine, for example, is not on, say, the BC formulary. There was a point where my pharmacy in Vancouver, we were trying to import the diacetylmorphine for our injection program, and legally we could, but we ran into issues of just not being covered. So we had to use the other substances. And physicians as well. I mean, yeah, there is a bit of concern about their professional liability. You have to understand they're signing off on these prescriptions, even though it's there's a lot of support behind it. It is a new thing, and there's been years of sort of pressure on physicians to almost lower the amount of opioids they're prescribing, and now suddenly the safe supply comes out. So it's just a whole different ball game here. So if we go to the next slide. So I'm going to go over the medications quickly that the BCCSU, so it's the BC Centre on Substance Use. This is what we used in BC. It can vary again from province to province, but this is something we would actually see pretty regularly. So prescription for hydromorphone 8 milligram tabs, and the SIG would be 1 to 3 tabs every hour as needed, up to, there was sort of a soft maximum of 14 tabs a day. Prescribers could easily write 6 tabs a day, 10 tabs a day. There was definitely options there. Physicians could also use long-acting morphine, a 12-hour formulation, and these could be used alone with each other or in addition to like opioid agonist treatment, so like a 24-hour morphine or a methadone. And we'll go to the next slide. These ones I'm not going to talk too much about just because of time, but in BC we had access to stimulants as well. So dextroamphetamine, methylphenidate, so you get pretty high doses on them. Of course, we're trying to compete with things like crystal meth, which these really don't, but it was something. And these stimulants could be prescribed in combination to each other, along with the opioid safer supply, and also in addition to an OAT product. So we'll just sort of keep going on to the next slide. And again, in BC, we had access to guidelines for benzodiazepines, of course, tobacco and alcohol, but we won't get into those with this presentation today. So we'll go to the next slide. So what does it look like in pharmacy? So if you're standing in the community pharmacy, how does safer supply look to you, or how could it look to you? Honestly, I just want to say, if you can dispense hydrochlorothiazide or metformin, you can dispense safer supply. It's the same kind of thing. It's just a different drug. We do need to be responsible for doing follow-ups with clients. If they're coming in and they're very drowsy, why are you drowsy? Is your dose too high? Maybe we can lower. Are you drowsy because your dose is actually too low and you're still buying stuff on the streets, which is also very dangerous, of course. Maybe we can look at increasing your safer supply. If you're only on, say, 10 hydromorphone tablets a day, maybe you can go up to 12 or 14 a day. So we still need to, as pharmacists, observe our patients and care for them like we would with anybody else. I don't see it as that big of a difference. It's kind of just a different drug for a different condition in my mind. Things like hospitals, looking at other pharmacies or cities. Yeah, initially when we had some transfers and things happening, yeah, we would call ahead to their pharmacies. But honestly, most pharmacies carry hydromorphone and methylphenidate. So most had it in stock. We worked very closely with the hospitals. A lot of our clients were in and out of hospital. So we just had very good systems in our pharmacy to give sort of almost real-time data of who took what dose and even at what time to help the hospitals out. I think one of the biggest things you can do in your community, if you're not already doing much of the safer supply, is actually reaching out to some of the local prescribers. Ask them, if there's more you can do. I would say from experience, if you kind of sit there and wait, you might have 4 or 5 different clinics asking you to do 4 or 5 different things. So sometimes by reaching out to a few of your clinics in your neighborhood, you can kind of offer them, here's what we can do. And then you have sort of one program in your pharmacy, and you can maybe reach out to all the physicians and know that you have their support, and you can support each other really. Also, reduce barriers for people looking for safer supply. We had a lot of people come into our pharmacy all the time asking for it. We didn't have a prescriber in our pharmacy, so it was just knowing where to send people at what time, what clinics were accepting new patients. So rather than trying to make phone calls or look something up on the internet, we just had little sheets like, here's take this with you. It's 2 blocks that way. They can look at you today, that you can probably get a supply today. And the most important thing, anybody coming and going asking for any kind of safer supply, is make sure they have a naloxone kit, make sure they know how to use it, and ask if people around in their inner circles, make sure that they know how to use it as well. Go to the next slide there. So limitations. I mean, it's actually quite shocking in some ways that we do have this program, but at the same time, I've been working with it for over 2 years. And at the same time, I don't want to throw anyone under the bus, but it should have actually been around probably at least 5 years ago, in my opinion. There are a lot of limitations with it. So not enough people living with opioid use disorder are accessing safe prescribed alternatives to street drugs. And again, when I do say safer supply, personally, I don't just want to focus in on opioids. I know the presentation is, we are talking about opioids, but if we only focus on opioid use disorder, we are missing thousands of people that have, say a stimulant use disorder that needs addressing. So there's not enough people with getting access to it all across from coast to coast to coast. Not enough doctors are prescribing to patients. And yeah, the medications available to prescribe, they're just not strong enough to compete with the illicit drugs. 5 years ago, a hydromorphone tablet it's pretty equivalent to a hydromorphone tablet on the street. But now we're trying to give hydromorphone to people that are tolerant to things like fentanyl and even carfentanil. There's people that are on, they actively seek out fentanyl in Vancouver. That's all. And even they're not even really getting euphoric effects from it. It's almost to prevent withdrawals. So we're trying to play catch with this illicit drug supply that just keeps getting more and more potent. So we need to quickly expand the amount of drugs that are on it. I'd also say the greater number of both the medications of safer supply, but also just an expanded accepted routes of administration. So this was something that actually kind of blew me away. In 2020, the BC coroners reported that 56% of overdose deaths in BC were actually from smoking, whereas only 19% were from injection. So I look back to my old program of the injectable opioid agonist treatment program. Yeah, it did take on a lot of people in that program. It was very successful, but we do have to think of other ways that people are using medications. The frustrations people get with trying to inject and not being able to find a vein. Yeah, that's why we are seeing this switch to people smoking and other forms of administration. And then this is sort of a quick wrap up here. So the overdose crisis has killed 1,200 more British Columbians than COVID-19 has in the past 2 years. Replacing toxic street drugs with a regulated legal supply is the, quote, single most important thing we can do. This is according to the chief medical officer with Vancouver Coastal Health. I do want to just say, that's great to hear somebody in that power, in that position to say something like that. I mean, it's not a competition, but I do feel like I think I kind of said something like that 3 or 4 years ago, but it's great. It's not a competition. It's all good. I'm just happy to see people in power making these comments, and I hope that we can move forward with this.
That's great. Thank you so much, Craig. Oh my goodness. Some of the stats are pretty alarming. I have a few questions, but I'll invite our attendees as well. If you want to ask any of the panelists questions, please type it into the Q&A box. But we'll start just by getting the reaction. Mike and Maria, what are your thoughts on what you've heard from Craig's presentation?
It's a great presentation, Craig. It's always great and valuable to listen to you to speak and share your expertise. And so some quick thoughts, and I'll elaborate on some of these as we go. There's so much knowledge that comes out of experience. And one of the challenges we have is with a little bit of lack of research in this space, we really need that practical experience, and we need to share it so that others can replicate it. And along those lines of research and education, every one of those slides and almost every bullet point had me thinking of 5, 6 research questions to ask because we just don't know enough, and we need to learn, and we need to learn quickly in this area.
I think just building upon that, thank you again for the presentation, Craig. I think the 2 things that jumped out to me in your presentation was, that old adage of meeting people where they're at, and that being incredibly important. And that is really kind of tailoring our treatment approaches to the person in front of us. So I think it helps me kind of reflect on, the assessment of our current strategies as the medical profession, as pharmacists, as to why they're not working, right? I think in our panel discussions prior to this one, we talked about the fact that, methadone's been around for half a century. Buprenorphine's been around for decades. Take-home naloxone kits in Ontario is freely accessible. And we know that equity and access to them still is quite variable depending on geographical location, and so many things that are probably still mired in stigma. So, I'm curious as to how we can reflect as a profession on really kind of decreasing some of those barriers and access to evidence-based approaches. And for me personally, I'm curious as to why aren't people interested in opioid agonist treatment? I think people call methadone liquid handcuffs. So is it because of restrictive dosing? They're in withdrawal for too long, geographical, financial barriers. I think you've highlighted that, the dual crisis of both COVID-19 and the opioid poisoning crisis. They're also kind of tied to so many other things like basic income, housing, criminalization of substance use. So I think all of these are paramount for us to consider. The other thing that kind of jumped out to me was also the pharmacist and prescriber collaboration, which I think is obviously key to any of the work that we do, but perhaps even more so when it comes to supporting individuals who use substances. So I think, you mentioned to the group for pharmacists to reach out to the prescribers in the community. And I think that's a really important approach in thinking about, when you have a client coming to you with safer supply, what does that program look like? Because I think as heterogeneous as access is to safer supply, we're also not really sure what safer supply looks like in terms of different models and approaches. We know that Health Canada has, about 24 programs that they're funding, but they're primarily based in community health centers with really kind of intensive and robust primary care services. So is that kind of, to Mike's point, from a research perspective, similar or different than solo practitioners? So I think those are all kind of really curious pieces, and thinking about like what are those patient-oriented outcomes that we're really looking for? Because to your point, we can't displace the entire unregulated drug market while also padding the wallets of pharmaceutical companies doing that. So really kind of thinking about what are those key nuggets of collaboration that we need to focus on, and again reflecting on our own practice as to what barriers we're implementing implicitly or explicitly in having people access that spectrum of evidence-based approaches to care.
Such good thoughts and so much to reflect on. I know we're not going to be able to address it all today, but what types of government programs currently exist, and what initiatives would be a good opportunity for pharmacists and stakeholders to explore, to at least just start?
I can start with that one. So many of the safer supply programs are currently funded under a substance use and addictions program funding. That's federal. There are other models as well at the provincial level. And those SUAP, the acronym SUAP, those programs have been great, and they've been focused on, quite rightly, on short-term impacts during a crisis like such as we're in. But they're sort of grant-based, time-limited programs, and sometimes they have limited allocation for research and sustainability. And so you end up with some great work being done that isn't guaranteed to be funded in an ongoing manner. And so we need to continuously call for sustainable programs, especially ones that have been demonstrated to be effective.
And I'll just add briefly, I see Robin put a comment in the Q&A portion. I think, as we mentioned in our OCP Safer Supply article as well, I think a lot of these practices are grounded in kind of grassroots initiatives. I think, people like Craig kind of leading the way, especially in BC, as to what safer opioid supply looks like. I think having that community of practice in the absence of evidence as it's being generated through those SUAP proposals that Mike spoke about, I think it's really key to have people to kind of bounce ideas off of. So joining, those communities of practices, those listservs on your own kind of provincial safer opioid supply listserv or the national one, I think is one of the key ways to kind of maintain your own knowledge and expertise to like a very quickly evolving network of different services that are being offered. And I also think it kind of prompts you to think about, some of the challenges you might face when it comes to drug shortages, or I think we're seeing on the listserv, how do we, support clients who also have concurrent other polysubstance use while on, many tablets of prescription opioids plus slow release oral morphine plus methadone. I think these are incredibly complex patient cases. And I think it's important to kind of work that out with other people. So I think that highlighting the listserv is a really great initiative, and happy to kind of amplify that, Robin.
I think it's such an important point, and it just speaks to one of the things that we had discussed in that there's no there's no set clinical algorithms or guidelines to really help support and even the research and the evidence to help support these clinical decisions. A lot of them come from experience, and so how do we as a community build that knowledge, share that knowledge, and get comfortable working in this space, and continue to push ourselves and our practice to that next level where we're able to really give our patients a level of support that hasn't been achieved. It's similar in the sense that we're deviating from traditional therapies and moving into patient-centered care.
Yes, in the harm reduction space, we're used to a sort of pharma-driven medical world where they'll come up with the drug and show that it works and show who it works in, and then we can review that and implement it. Harm reduction is usually sort of happens to address needs, and it's often in the case of substance use users themselves or groups that work with substance users who are initiate and pilot some of these things, which means they're happening in urgent situations, and there's generally, at least initially, they're low data areas, and so we need to sort of just switch our thinking as far as medical evidence goes to incorporate evidence and clinical practice, and it's not a space that medical practitioners generally and pharmacists are particularly comfortable with.
We're getting a lot of questions here in the chat box. I have a question here. Is all safer supply being used under supervision at supervised consumption sites?
I would say unlikely that it's all being used at safe consumption sites. That is part of the idea of the safer supply, is they can use it on their own time, that they don't need to sort of have us watch them do it or the supervised consumption sites monitor it. Ideally, again, these are still powerful opioids and things can go wrong, especially with other underlying chronic conditions. So always encouraging people to have like a buddy, have somebody watching over them. But no, not necessarily at an authorized supervised consumption sites. In Vancouver in particular, a lot of the downtown east side buildings, they actually have a room. So there's 200 SROs, single room occupancy beds, somewhere near the main office area. They'll actually have a couple of safe sort of injection sites with a camera on them as well, and everybody's trained with naloxone. So that's the way we see it down there.
Yeah, in most supervised consumption sites, they're there to assist, and the people attending bring their own drugs, and that could be drugs they've obtained through a safer supply program, or it could be drugs that they purchased from the unregulated market. So it could be both or.
One of the other, I guess, fundamental questions that I had is, what does success look like? Is the goal the eventual elimination of opioid drug use altogether, or is it abstinence from street drugs? I know the answer may be different depending on the individual, but I'd welcome your thoughts on that.
I think, Danielle, to me, you've answered the question around, it really is kind of patient-driven outcomes. And I think, the word patient has its own kind of connotations to it. But I think a lot of the markers of success are related to, what that individual has deemed to be a marker. I think for some, some people within the medical space, it's, perhaps it is, again, these goals are decided in collaboration with the individual. So maybe it's, remission, so that this person doesn't actually meet criteria for opioid use disorder anymore. Maybe it's mending family relationships. I think some of the research that we've seen come out of some of the safer supply programs in Ontario have indicated that, individuals have been able to decrease their involvement in sex work or criminal activity, which was previously used to fund, their use of drugs from the unregulated market. I think, there's other pieces. I think, as Craig mentioned, the person's engagement in other primary care services as also perhaps a marker of success or treatment retention. I think, that's the data that we've seen so far. And I think I'm curious as to future data that's going to come out of safer supply programs, kind of delineating what is it about the safer supply programs that contributes to those positive outcomes. So is it literally the provision of the opioid itself? Or is it because, Health Canada, the 18 that's been funded, they're in, again, primary care settings with very robust services, Hep C screening, HIV treatment, with very empathic healthcare providers. Like, these are the individuals who spent the time and effort to put in this long, arduous application to Health Canada, received funding because they have demonstrated that this program is worth funding. Is it because that they have an ideal healthcare setting delivered by an ideal group of people that's actually kind of contributing to the outcome? So I don't know if we'll ever have the exact answer as to what really drives some of the success. But I think, as we're hinting at through this discussion, safer supply looks very different depending on, geographical location, but also, is it solo practitioner delivered? Is it community health center based? Is it a fee for service model? I think that is also part of the further evaluation that we're awaiting as well, is to like, again, what are some of those drivers of success? And I think in the chat box, a lot of attendees are also wondering about diversion, whether they've seen it in their own clinical practice, or, this is something that also is very intuitive. Like when you give out so many opioids to people, is it likely that the person's going to consume every single tablet? And I think that's also something that we're curious about as well, because we know to address any epidemic, it needs to be a multifaceted approach. I think the minister mentioned kind of enforcement, harm reduction, treatment, but also prevention as being one of the key pieces. So, if we have, individuals who are getting, high quantities of opioids, are any of those opioids making its way to, people outside of prescription for which they were intended? Sorry, there's a code at CAMH. So I think that's one of the big concerns that is probably, a question left remaining for the group around that diversion risk, because, people don't start with injecting fentanyl or smoking fentanyl. I think usually there's kind of a trajectory of substance use. So I think that's something that, we're waiting further data on as well, just kind of the risk of diversion and impact. I know that, oftentimes people are diverting to support other people who are in withdrawal from an altruistic perspective. But we also know that the current opioid crisis was preceded by, heroin expansion of the market, which was preceded by prescription opioid overprescribing and mass marketing to prescribers, and underestimation of its impact. So I think we kind of need to kind of keep a very holistic lens to this topic for sure.
Thank you, Maria. I'm getting some questions here just around, maybe Craig, you can speak to this, around the dispensing. What is the usual interval? Are meds covered? Anything you can add to?
Yeah, so quite fortunately in BC, I think the program was designed around what the pharmacare formulary had. So it is as simple as filling a blood pressure medication. Generally, they are daily dispense. Sometimes you get carries for people if they're traveling and they're traveling somewhere where they can't access the safer supply. It is literally, here's a prescription, no different than say methadone or hydrochlorothiazide or metformin, happens to be generally daily dispense. And it's just basically it's the number of tablets. So we would sort of pre-do all these little pouches for people, and they would just come in each day and we would just give it to them, and we would sign off on a log sheet like we would for methadone. It's unwitnessed, but we're witnessing them take the medication with them. As far as billing, nothing at all different. We just run it through like a prescription, and it just goes through daily to the provincial pharmacare program in BC. So nothing complicated at all. Hopefully, I don't know, each province has different ways of doing that and billing it. I know in BC it was set up actually very, very easy and straightforward. So it was, I don't know how I'd really improve on that from the pharmacy processing and filling and dispensing aspect.
Thank you. There's a question here about any plans to increase awareness about the risks of injecting tablets. Often pharmacists aren't aware that their patients are injecting the prescribed tablets, and maybe that dialogue isn't happening. And so any comments around that? Do people really understand the risks involved?
I mean, I think that just means greater lines of communication between pharmacists and the individuals that they're working with around, like, when you're providing the safer supply, I think the very least you can ask is, how do you plan on using these, when you get home, and providing individuals with, different ways to minimize, again, some of the harms associated with it. I think we've mentioned, to Craig's point, ideally use at a safer consumption site, although I think the minister mentioned that there's 38 in Canada. Canada is a very, very large country. So the chances of someone being geographically co-located to a supervised consumption site is relatively lower. But whether it's perhaps, having the correct filters so that you're, minimizing some of the exposure to the excipients or, all the things that aren't meant to be injected, or just informing people about some of the different skin and soft tissue infections, but also consequences of abscesses associated with injections in general. and just, ways to inject more safely in terms of clean needles, and making sure that they are freely available to individuals as well by partnering up with a public health agency, for example. So I think it does take work, but I think it's all important work that pharmacists can be doing to support individuals who use substances.
Yeah, I agree. And I think what I always kind of suggest too is, what are we competing? Like, what are we comparing? We're comparing somebody buying illicit drug supply and injecting that versus at least the pharmaceutical grade. To me, it's not a comparison. I mean, yeah, the safer supply is meant to meet people where they're at. This person is doing this right now, whether there's safer supply available or not. The idea is you're getting 8 milligrams of hydromorphone in this tablet. Yeah. Again, greater expansion of the medications on the formularies. We need to be prescribing medications that people can use in a form that they need to, that they want to consume it by. And to the earlier comment too about tablets that may go maybe diverted from the program. It raises a bunch of questions too about, well, what is that person diverting the medication for? Why is this person selling their hydromorphone? What are they buying? And then the answer is, well, we need to be dispensing the medication that they're actually buying. So whether they're trading it for crystal meth or some other kind of stimulant, we have very little options for stimulant safe supply. They do not compare. Methylphenidate just does not compare to crystal meth. It's worlds apart. So, figuring out where these tablets are going, why they're selling them, well, it's probably a couple things. There's not enough on the formulary, not enough choice. And there's also probably, excuse me, grab a little bit of water here. Not only choice, but I think just the mechanism which people want to consume, we need to really sort of accept that people are using it in different forms. I know for the tablets in particular, the brand name, and there was one of the generics, the kind of more triangular shaped 8 milligram tablets. They did actually, or do seem to inject much easier and safer. There was another third generic company makes a little round tablet, and it used a bunch of talc in their fillers, and people were actually finding that they were very hard to inject. So when there was drug shortages, some people didn't have a choice. We had to dispense the little round ones, but our preference was always either the brand name or the actual generic triangular shaped one, as it didn't clog up in the syringes as well. But yeah, ultimately it's safer than injecting the tablets. Is safer than injecting an unknown source of a tablet. So. And then ideally, once we get them in the healthcare system and we're seeing them daily, yeah, at their pace, maybe we can switch them to a less intense, less invasive form of opioid agonist treatment. That is a goal, but it's not my goal. It needs to be the patient's goal.
Right. One of the questions, or one of the areas that we haven't really touched on yet, is the stigma. And, just the idea that there's a lot of stigma still within our profession and institutions. Any thoughts on how we can help combat that?
Yeah, I would say, reading material from harm reduction groups or from presentations from people like Craig, it doesn't take very long to understand how the language being used is different. So we're not talking about addicts. We're talking about people who use drugs or people who inject drugs. When we think of stigma, we think of blame, but stigma is also a barrier to communication, and it comes from the patient or the individual, and it comes from the health professional. So in my experience in the area related in naloxone research, we found that patients didn't want to ask for naloxone kits because they didn't want the pharmacist to think that they needed one. And the pharmacist didn't want to ask the patient about a naloxone kit because they didn't want the patient to think that they were suspicious of their use. And so, talking about these things, frankly, and we've seen a good example of that with Craig's presentation today, is, these are opioids. They do a certain thing. Naloxone is an antagonist that does a certain thing. And sort of related to one of the questions from Nicole in the Q&A box, it's, we base our practice around indication, and, there's a reason you're taking a prescription. And so one of the things that I like to do is just stretch that word a little bit to include reasons for use. And so your indication might not be today to treat opioid use disorder and enter a treatment program. Today, your reason for use might be to avoid withdrawal and not use an unregulated opioid. And so if we expand that indication, I think it helps with some of our thought process, and that can also help with reducing stigmas. It takes away the why and whether you should be doing this and who should be. And so yeah, stigma is a barrier, and it's everywhere, not just, condemning people, but it's a barrier to communication too.
Absolutely. I agree with Mike in that stigma exists at every level. So like the internalized stigma that people who use substances feel as a result of interacting with others who have cast that air of shame. And I think it's also, we see it in the healthcare professions. I think, one of the questions in the Q&A had to do with how do we address stigma within the profession? And I think the first step is to know that, one, it exists, right? It's not just elsewhere, it's within pharmacists and pharmacy as well. And I think there are tools for us to actually assess our stigma. And I can certainly share that with the group afterwards. But I think recognizing that stigma also kills is really key, because stigma is not only a barrier to accessing treatment, but we know, to Mike's point, we know that people don't call EMS, or they don't, go follow up within the emergency department following an opioid overdose because of the stigma attached to substance use, and also, criminalization of substance use and law enforcement and all the risks that carries in and of itself. So I think, just acknowledging that it does exist at every level, I think is really key, and also reflecting on where it affects us. So, thinking about the monumental efforts that we've implemented as pharmacists, as pharmacy technicians during the COVID-19 pandemic, screening, vaccinating, handing out rapid antigen tests, so whatever kind of head office decides at the moment in time. There's been explosion of all these efforts to combat the COVID-19 pandemic. And at the same time, as Craig mentioned, the opioid crisis has only gotten worse during COVID-19. And so we haven't seen, at least to my knowledge, an expansion of access to opioid agonist treatment, to take home naloxone kits. If anything, we're hearing, shifts in that. So I think it's really key for us to kind of call out, like, why aren't there differences or parallels when we have these concurrent pandemics or epidemics? And is it just out of volition that we don't want to do this, and why that is the case? I think, one of my mentors, Zubanas Mooncock, talks about the mental model that we have. So, what is it about, individuals who use substances that we have, differences in what we offer at our pharmacy depending on a medical condition? I think we jokingly discuss, we don't offer metformin or insulin when it comes to diabetes management, but, there are very clear discrepancies between accessing OAT in pharmacies. And it is kind of curious for us to reflect on all the reasons why. It might be kind of financial off the bat, but really kind of delving into, why don't we offer these services? I think we'll probably uncover some of the implicit or explicit stigma there too.
Thank you. And, building on that, I think we're running out of time here, but building on that, I guess the question is this an area of medicine that all pharmacists should be involved in, or should it be integrated into standard care? Is any thoughts on that?
I think, maybe not all pharmacists are going to set up a 60-person-a-day hydromorphone dispensing program tomorrow, but I think that there's pharmacists that might include some of this work as kind of an integral piece of their practice. But then there's that group of sort of pharmacists that are peripheral to that may be involved, or some of their patients may go, be involved in these programs. And so it's important to get involved and to do your best to tackle this opioid epidemic in the way that you can.
Just building on what Mike mentioned, I think just based on the current evidence that we have for safer supply, I don't know if it's standard of practice for every pharmacist to be providing it at this point. because I think there are some questions related to risks that we haven't yet ironed out. I think, to Craig's point, knowing your patient population, knowing your prescribers, and knowing what services serve your community best at that time, I think is also simultaneously important. And I think, in pharmacists who are setting up safer supply programs within their pharmacy, I think that close communication with prescribers is absolutely critical, because of all the things that we discussed in terms of what are those benchmarks for success of the program for the individuals who are participating in the program. And let's also lend our thoughts to the evaluation process as well, right? These safer supply programs are instrumental, and the value of pharmacies and pharmacists are key there as well. So whether it's creating those research questions or making sure that pharmacists and pharmacies are represented in that evaluation framework, I think that's another key piece for us to contribute to.
And it looks like we're coming up on the hour mark. So I think we'll stop there for questions. But before we close, I'd like to ask each of the panelists to offer any final remarks and even to share what you think is the one most critical element from today's discussion that you'd like our participants to leave with.
I think the things that come to mind as barriers are burnout, confidence, and this feeling of helplessness. And so the burnout comes from the fact that in many workplaces we've been overwhelmed in the last couple of years by another epidemic, and thinking about an opioid epidemic now or thinking about adding anything new to our practice can be kind of intimidating because we're not feeling ready to tackle something. The confidence comes from knowledge, and I think Craig and others have alluded to it already. We know how to dispense opioids. They might be a different type and they might be for a different reason, but a lot of that process is the same. So you have that knowledge already. And that confidence also comes from stigma. So feeling more comfortable speaking about opioids is a way to gain that confidence. And I think that feeling of helplessness, if you're reading just news headlines about opioids and opioid overdoses, it feels overwhelming. It feels like a disaster that's unfolding that we're, what can I do? But everything helps. So if it's not participating in safer supply, just checking in more regularly with higher dose opioid patients, dispensing naloxone to everyone with an opioid prescription. And if that's too much, start with people over 90 milligram equivalents of morphine, putting a pamphlet to a rapid access addiction clinic in your pharmacy if there's one in your region. So everything counts in a crisis, and even something that might feel small will have a significant impact.
Yeah, absolutely agree, Mike. I think a recent publication in Lancet projected that 1.2 million people will have died of opioid overdose in North America by 2029, which apparently is only 7 years away. So I think it just speaks to the helplessness and hopelessness that some clinicians feel, and this kind of moral imperative to do something as soon as possible. And I think, to Mike's point, everything contributes to us, providing those evidence-based approaches that literally decrease mortality associated with opioid overdose in the fentanyl era. So, at the very least, let's provide opioid agonist treatment, those take-home naloxone kits, and reassess, what our mental models are of individuals who use substances, and how that impacts the care that we deliver, and if it should, which I think, arguably, no, it shouldn't. And I think, that's kind of the main thing that I would highlight there. And I think the main piece that Craig emphasized in his presentation about meeting people where they're at is something that I think is continuously important. And that means, if that person's not interested in OHE at the time, if safer supply is the best way to engage that individual, I think that close collaboration with the entire team, with the person in front of you, is a great way to kind of keep moving towards, the client's goals for themselves, and doing that collaboratively.
Yeah, I think what I would just say is if you're not currently doing safer supply, please consider it. If you're not dispensing naloxone kits at your pharmacy, please really consider it. I don't, if you're giving out an opioid and you're not giving a naloxone kit, you have to think about the consequences of what could happen with that. Something I've kind of noticed with a lot of these either webinars or conferences and talks that we do, see almost the same kind of group of people showing up to them. And I went through some of the participant names. I noticed a bunch of people like, oh, it's the same group of like 25 or 30 people. So one of my goals or one of my wishes is if we could just expand what I'm doing on a very small scale. You don't need to have 200 OAT patients coming into your pharmacy every day or have 200 delivery patients. Even if you just took on 4 or 5, it can make a difference. Just please consider it. And if it's not for you, that's fine, but don't be rude. It's like saying, oh, I'm not going to take on diabetic patients in my pharmacy because I don't really want to deal with it. But it's a medical condition. There's emerging evidence, not only in Canada, but around the world, that meeting people where they're at is successful. And, if you don't like evidence-based medicine, then I guess you can turn a blind eye to this.
Awesome. Craig, we're going to consider this a mass spreader event. Maybe it's too soon to say that, but we're going to multiply this movement of clinicians that are happy to work in this space. So thank you all very much for your contributions today. And that takes us to the end of our session. On behalf of CPHA, thank you for joining us. And a very special thank you to our panelists for their time, energy, and expertise, and for sharing your experiences with us. And a big thank you also to Minister Carolyn Bennett for sharing in our discussion today. Once again, this webinar will be recorded and will be available on our website within the next week or so. And please remember to fill out the evaluation survey once we conclude the webinar, just to give us a better sense of how we can improve our webinar offering. So thank you very much, everyone, and I hope to see you again soon. Take care.